Thank you very much, Mr. Chairman, for your kind words. This is a kind of a joint session of South Asian Health Foundation, UK, and Diabetes India. So I'm thankful to Diabetes India, Banshi, Manoj, Shashank, and the others for having this session. We had a similar session of Diabetes India at our annual conference in Birmingham in the UK last year. So it's good that we're working with our Indian colleagues on this issue. Now, the topic that I've been given is slightly bit confusing because I would have not chosen this topic myself. It's current goals of type 2 diabetes treatment. Is good glycemic control is enough? My answer is very easy. Good glycemic control is enough for managing diabetes. And the reason I say that is because I trained to be a sugar doctor, and you know, whatever people talk, the primary issue is still the sugar. Although I'll talk about the cardiometabolic renal agenda, which is fine, it is being pushed, and we will try and examine how it is, and especially because my area of research interest has been the South Asian populations in the UK. I will try to give a South Asian or an Indian angle to it. Now, you must have all seen this slide, which is used in multiple presentations. Rest in peace, died with a perfect HbA1c. And especially with SGLT2Is, this was promoted, I think by the ADA, I don't know, with known diabetes by heart. So let's see where it comes from. Now, this is very well known. This is that nearly 2/3 of deaths in diabetes are attributable to cardiovascular disease. Although this paper is from 2016 and the rates have come down, but still most of our patients with diabetes will die from a cardiovascular event. Now, to understand diabetes, we just need to take a step backward and see where does the definition of diabetes comes from, and this is where there is an issue. So when Alberti went out to Tanzania and looked into the eyes and gave us diabetes, the definition of it, not the thing of that, it was just based on a single criteria: the glucose levels that causes background retinopathy. That was the criteria for diabetes. And since then, all the definitions, whether the ADA brings it down to 5.7 or the Brits get it to 6.5, Indians do postprandial, it is still based on the microvascular complications of retinopathy. So, if you're going to treat a disease whose endpoint is microvascular disease and expect a kind of a good macrovascular outcome, there is a bit of a paradox, and we all need to be aware of that. So let's examine the natural history of type 2 diabetes. We all know this, we are not going to really go through it. And we actually go from a phase of pre-diabetes, you can call it insulin resistance, obesity, to developing of microvascular, macrovascular complications. Now, this is a 20-30 year journey of our patients. But the point that we are still not sure is at what point of intervention do we prevent macrovascular disease, specifically cardiovascular disease. We know the point for microvascular disease, but we still do not know the point for macrovascular disease. Now, let us look at the Indian phenotype, which is very interesting. Now, one of the things when we look at the prevalence of diabetes in an Indian population, we talk is 15%, 18%, 120 million. The way I look at it is, what is the lifetime risk of developing type 2 diabetes? And if you are an Indian, it is 64.6% for a woman. So nearly 2/3 of the people are going to develop diabetes in their lifetime, and nearly half women and nearly half of men are going to develop type 2 diabetes in their lifetime. So which means that just targeting sugar is not going to be enough. We will probably need a kind of a multi-pronged approach to really look into it. And this brings about the story of the two types of diabetes in the two Indians. One is the Western concept of diabetes, which we have got from the Pima Indians, and then is the Asian Indian phenotype. Again, I don't have to go into the detail, but this is a thin person. Perhaps the beta cells are not working in them. they have got low beta cells. We had an excellent talk by Ranjan, who's presently chatting to someone else about the low beta cell mass in an Indian cohort. So their insulin level, so if you're going to measure C-peptide, is going to run low. So again, glucose becomes important. This is our early work which we did with the United Kingdom Asian Diabetes Study, which cohort we set up 20 years ago, and really confirmed this, that if you are a South Asian, your HbA1c will be higher at the time of diagnosis, and throughout the secular trend of 20 years they were followed up, there was a 1% difference between a white European and South Asian in terms of their diabetes, and their cardiovascular risk was they died 10 years younger. So before we talk about whether we need a glucose-centric approach or a glucose-centric target for managing type 2 diabetes, we need to ascertain which type of diabetes does a person have. And this is a paper which was published in this Lancet Diabetes Endocrine. There have been other papers published by Shashank and others from India. Again, talking about all of these are observational based on cohorts, really talking about various types of diabetes. So if you have got mild age-related diabetes, glycemic control doesn't matter. In obesity-related diabetes, it's more about managing weight, managing cardiovascular risk. Diabetes control does not matter. But if you have what we call severe insulin deficient diabetes, which we see in Indian cohort, then glycemic control is important, and you cannot forget the glucose levels. So now this is some very interesting data from the United States, which actually compares population with diabetes or without diabetes, and it actually shows when it comes to cardiovascular complications, they are coming down, and they're coming down pretty dramatically, both in people with diabetes and without diabetes, more so in people with diabetes. And this is probably not due to glucose management, it is due to better cholesterol management, less smoking, more exercise, and perhaps obesity. But if you look at conditions like end-stage renal disease or microvascular complications, they are pretty stagnant, and they're not really shifting. Now this is again a very interesting data from the Swedish National Diabetes Register, and it actually shows, it looks at, which has been a big population followed for nearly 6 years, and it actually shows that if you manage all the risk factors for diabetes by whatever medications, you actually improve the lifespan of people with diabetes more than people without diabetes. So that is an important tool that we have got now, that we have got enough tools in terms of blood pressure, cardiovascular, and other management that we can improve. So what do the cardiovascular outcome trials say about people with diabetes, both in terms of glucose and the others? Now most of the drive for managing or looking at a cardiovascular outcome approach for managing diabetes rather than glucose-centric came from the GLP-1 trials, although the SGLT2 trials actually started it. If you actually look at all the SGLT2 trials except EMPA-REG, there are very few clinical trials that actually showed a cardiovascular benefit in terms of cardiovascular outcomes. I'm talking about myocardial infarction, cardiovascular death was only seen in EMPA-REG. But if you look at the GLP-1 CVOTs, they actually show a trend. This is a meta-analysis showing that they may have a cardiovascular benefit. Now what happens when we look at the index of glycemic control? Now if you look at the index of glycemic control, this is a meta-analysis of all the known glucocentric trials in terms of cardiovascular outcome, and you could see that actually they slightly point towards better glycemic control, improving cardiovascular outcome. Now if you look into this more closely, definitely the effect is the effect size is much more stronger for microvascular complication, but even macrovascular complications or mortality, you start seeing a positive effect in terms of good glycemic control, in terms of reducing the risk. So how do these trials fit into the whole cycle of diabetes? So here if you look at the UK PDS trial, It clearly shows a benefit both in terms of microvascular and macrovascular complications. As we know, in the UK PDS, these were newly diagnosed people with diabetes who had intensive control. In ADVANCE, which was a trial in patients who already had established cardiovascular disease and over 10 years of diabetes, you see microvascular but no macrovascular benefit. In ACCORD, in which people had advanced cardiovascular disease along with advanced diabetes, you see a microvascular benefit but see a macrovascular harm. VADT was unequivocal. So what you are trying to see is whether the glucose-centric approach works or not depends not only on the type of the patients, the type of the diabetes, but the history of diabetes when you are intervening. And this is very obvious from the treat to target approach, intensive to begin with, and then you do it. But to the proponents who say the glucose-centric approach is not for diabetes, you need to go back. So this is a very interesting, the DASG study, which actually was one of the first studies that shows it was possible to prevent diabetes, and you could prevent diabetes by intervening in the pre-diabetes. And this is the a post hoc analysis, so which was 10 years after the cohort. And what it actually shows that in the patients who managed to lose weight or reverse diabetes, they were getting a cardiovascular benefit even 20 years down the line, just showing that early intervention, even if it was for a short period of time, that delays the diabetes, which is a glucocentric intervention, has a positive effect for a long period of time. We also know from the UK PDS that as the time passes, the glycemic control tends to deteriorate, and this is across the board. It doesn't matter which treatments do you use. Now in India and across the globe, the biggest challenge that we have got is the young type 2 diabetes. We had the Ahmedabad declaration earlier this morning, and this is looking at people. So young type 2 is defined as anybody who develops type 2 diabetes at the age of less than 50 years, and that these are the big cohort populations. And there was this meta-analysis which actually showed that if you have got young type 2 diabetes, you do worse than people with type 1 diabetes, be it in terms of your renal outcomes, be it in terms of your end-stage renal disease, retinopathy, and all-cause mortality. So again, suggesting that this is a group of patients which needs to be intensive, both in terms of cardiovascular as well as glucocentric management. So what do we have for diabetes? How much is glucose important, or can we completely ignore the glucose? Now this approach, which has been part of the ADASD, and you must have all seen it, does make sense. It does talk about glucose, but at the same time it is important to look at other cardiovascular profile and manage it. At the same time, things like diet, lifestyle, physical activity, sleep, is all important. Also, it's important as to which medication we use, how we use the medication, and again this depends upon not only the type of person who has got diabetes, the type of diabetes, the duration of the diabetes, and the complications. So the whole point of one size fits all is no longer there, and we will have to tailor what we call patient-centered approach. Although we've been using individualized treatment, we did not know who that individual was, and this really helps us to find that individual. Now this is the ADA standard for medical care. I think Kamlesh was part of this, and this does make sense in holistic approach, which talks about the evidence that for heart failure SGLT2 inhibitors have got the strongest evidence. For CKD plus albuminuria, again SGLT2 inhibitors, although there is evidence emerging with GLP-1s. For ASCVD, GLP-1s definitely have got a much stronger evidence than the SGLT2 inhibitors. So what are we really looking at? So the chairperson, so this is what my kind of a thing is when it comes to diabetes or type 2 diabetes and management. The diabetes, cardiorenal and heart failure is a continuum. So if you're looking at a primary prevention, which is be it at the pre-diabetes level or even earlier. At that stage, you are looking at programs that are going to prevent diabetes, be it stop obesity, or even when you're identifying pre-diabetes like NHS diabetes prevention program, you're trying to do everything to prevent that single person developing diabetes. And even if they develop diabetes, if you can postpone it by 2 or 3 years, you will be reducing complications. So I think that is where you get the biggest buck for money, both in terms of glucose management. Then you move into secondary prevention. So secondary prevention is when somebody has already been diagnosed with diabetes, and again you're trying to control the diabetes or the glucose levels much more rigorously so they don't develop any complications. If you fail, and most of us fail in that, you get into what I call the atherothrombotic continuum. So here you've got risk factors, which is dyslipidemia, hypertension, inflammation, stroke. So you get into the cardiovascular management. So this is about 5-8 years of diabetes. Here you're talking about management, so your cholesterol, blood pressure, healthy advice, making people quit smoking, doing comes in. If still the patient is not caught and he still continues, he gets into a renal continuum. In the renal continuum, you've got to measure things like ACR, follow the EGFR, and then you start looking at albuminuria, EGFR, ESRD, and treat them appropriately with ACE inhibitors, SGLT2 inhibitors, finerenone, etc. And then you finally get into the heart failure continuum, which actually can happen anytime during there. And here we have got the role of SGLT2 and other lot of medications that come in. So if you're going to explain the findings, should we even attempt to explain what I would call the unexpected. So glycemic control, it is time to onset too rapid, glycemic differential too small, inconsistent with previous trial, volume depletion, perhaps there is an explanation, risk factors probably have got the strongest evidence, and weight loss, again there is a lot of evidence emerging. So what's new in diabetes world? I always say it's the same thing: patient-centered approach, patient-centered approach, patient-centered approach. So this is some work I did with NICE few moons ago, and this basically look at the whole intervention strategy to prevent diabetes and prevent diabetes complications, and that starts outside the medical consulting group. It starts with what we call an upstream prevention. It is a good advice, be it managing diet, lifestyle in schools, having enough playgrounds for the kids to play, having enough social housing, and as Kamlesh mentioned, social determinants of health to stop getting people, and especially in a population like India, where the risk of developing diabetes in women is about 65% and men is 50%. You need these measures to get on, and then only it's going to possible. And this is a document's freely available. If you get a chance, just read it. Type 2 diabetes prevention, population and community level intervention. And finally, if you are not able to do that, now we have got the medications. These are going to cost you a lot of money. So this is a publication from New England Journal of Medicine, published quite recently on tirzepatide, showing when you use tirzepatide either in pre-diabetes or diabetes, it actually reverses diabetes and makes the HbA1c normal. But this is going to cost you money. Thank you.